just give us a little bit of background. You're a GP?
Yeah, I'm Marion Allwright. I'm a GP here in Belmont Health Centre, which is in Harrow. I've worked in this particular practice for nearly 10 years.
You're a chair of a multidisciplinary group.
Yes.
And could you just give me a little bit of history? I mean, what are the MDGs? How long have they been running?
They started up around about August, and we had our first proper meeting, case discussion meetings, in September 2012. Across Harrow we have 6 MDG groups, and we initially were meeting every 2 weeks. Each group met every 2 weeks, and the chairs would meet approximately once a month to run over the care plans, just revise, see how things were working,
And what's the idea?
What we do is we try and identify patients who we think have a need, whether that may be that they're frequent flyers, whether we need help with their case management. We meet in conjunction with other GPs in the group, with a hospital consultant, with, for instance, for diabetes, with a diabetic specialist nurse. We have a representative from social services, which has been invaluable, which we've never had before. There's also psychiatry present as well, because often a lot of the problems, there may be a psychological or a psychiatric aspect to a patient's illness. We also usually have representatives from district nursing as well. Each of the MDGs will cover certain areas. Initially we covered elderly and diabetes, but we've now added in COPD and cardiac. Probably though, in terms of numbers, the main focus is the elderly, and recently we've tried to develop something called Care Plan Plus for the older elderly patients who perhaps are more dependent, over 85 years, who perhaps live on their own, that don't come down to the surgery, who we would consider to be more vulnerable. A lot depends on practice size, so our particular practice is quite small, so our current numbers, our current targets are 6 elderly care plans per month and 2 of cardiology, COPD and diabetes.
How did you identify those patients in the first instance then? What process did you go through just to get?
Initially it was like the real, the difficult patients, the ones you're thinking we weren't sure what to do with them next. So they were probably the ones where there were a lot of complications and you just wanted input and advice. So, yeah.
Were those the ones that you felt would be most at risk of going to hospital if you didn't really do something proactively?
Usually, yes.
Right,
yes.
okay. So just go back then, so you identify those patients, you make contact with them, you give them a questionnaire. What happens after that?
Then we bring them in for the interview and we discuss the answers that they've made for the questionnaire and discuss what the expectations are. A lot of the data that's actually collected is the QOF data, so it's very much in line with that, so the blood pressure checks and foot checks, things like that for diabetics. And then we would try and set out a care plan and work through what they hope to achieve and what things we can help identify.
And just remind me, who's in that meeting then when that's happening?
Usually it would be the patient plus a carer if they have a carer or a representative, or it may just be the patient.
And who from your side is in the meeting?
Initially it was mostly with doctors, but a lot of the care plans are now being done by practice nurses. So some of the work, sometimes it's a collaborative effort, and some of the information in some practices I know is being collected by healthcare assistants, but most of the inputting is done either by nurses or by doctors.
Right.
I suppose one of the most important things we have is the issue of consent.
Ah, yes.
And I think certainly when we started, the issue of consent was quite important. And on the beginning of the template it says, do you have consent? Is the patient capable of giving consent? Do you have written or verbal consent? And we take verbal consent because if you've invited a patient for a questionnaire and they were attending, that implies consent, and you're asking them again if they consent. We do a number of care plans, so we perhaps do up to, for our practice, 12 care plans per month. That's our target. But of those, we'd only usually bring two care plans to the MDG meeting.
Right. And just sticking with the care plans, I mean, what does a care plan look like, and how much detail, and what does it sort of contain?
There's quite a lot of detail in them, and they are a little bit daunting to start with, but so much of it is aligned to the QOF. So, for instance, the diabetic template, a lot of the information is on that. So if they've had a nurse's appointment recently, it's quite easy to drag a lot of that information across. So a lot of it is more the trying to identify what problems or the barriers to their health, noting them to identify what they need, what they feel will help them make them better, or what can help ease help their day-to-day living.
How joint is the process? I mean, as an individual patient and a carer meets with yourselves, what does it feel like from their point of view, do you think?
It feels really nice. The patients, when you're writing the care plan, the patients seem to really enjoy the focus on them. And it's not just necessarily a tick box exercise. A lot of it is the working towards what they actually want to achieve and what things concern them. And sometimes things come out that we don't necessarily think of as doctors, that we don't see as being a problem, but for the patient it is a problem, for them to be able to talk about it. Particular patients. I can think of one elderly lady, and with her medications, she was on, she confessed that she didn't actually want to take alendronic acid for prevention of osteoporosis, and she didn't want to take a lot of her PPI for her stomach. And she's actually stopped them, and she actually showed me a drawer full of them and gave me a bag of them to take away. So that gave her the opportunity to discuss about that.
Right.
I suppose we reviewed her medications and we took out things that she didn't necessarily perhaps need, because she'd been on alendronic acid for a long time. So we felt that we could stop that, and she wasn't at risk of falls.
Excellent.
Lots of non-health services get discussed, so problems with housing, problems with carers, what kind of support, patients talking about social isolation, what sorts of things we can do to help them, looking at voluntary groups who might help, and that's where social services have been invaluable. They've been very, very strong with their input. So at the end of it, there's the joint thing where you can write out what goals you wish to achieve, and to try and get them to identify how they're going to achieve those goals.
Right. Kept by the patient?
Yes, yes. They get quite a slightly abbreviated copy that doesn't necessarily have all the drug information and all the past problems, but they do get a copy of what they hope to achieve. Right,
and that can be kept at home, can it? And, and carers can also look at it. And will the care plan actually also look at any particular risks and set up any I don't know, any contingent action if there is a fall? I mean, does it think into the problems?
It does, especially if they're discussed at the MDG, because we have the elderly care for LD, we have an elderly care consultant and psychiatry there. So if they need to access mental health services, if they need a referral to Falls Clinic or something like that, then that can be arranged. If we've had a problem with communication between the hospital consultants, then often they'll get on the phone there and then. And
the plan will anticipate certain problems and say, if this happens, then you should.
Yes, that's the idea, and the idea is to be available to the hospital as well, so that they will know that we've discussed and this is what the plan is for the patient.
Who would have access within the system to that care plan once it's been agreed then?
That's a really good question. I don't know whether I can
answer that completely.
I think the aim being that eventually they will be shared with the hospital. One of our initiatives that we've been looking at is trying to do the equivalent of a red book, like we have for children's health, for elderly or patients with chronic illnesses, so we can put the care plan in there, and it's a means of communication. It's like a handheld record that they can take with them if they need to seek other medical advice, perhaps out of hours, or to go to the hospital. So hopefully things will be more up to date.
Information. Does the care plan sit within EMIS, or where?
It sits within EMIS, yes. So it should be able to be accessed by other EMIS practices eventually, and also by the hospital eventually.
And can you how the MDGs actually operate? I mean, how long do they meet for? Who's at the table? And what's the process that you use?
We will have So there'll normally be about 6 doctors, there'll be somebody from one of the ICP coordinators there, there'll be the psychiatrist, the hospital consultant, social services, district nurses, and possibly some diabetic specialist nurses. If there's any business or outstanding, we will discuss that. We will then take it in turns to discuss the meeting, so over 2 hours, so for elderly care, 2 hours, we will each discuss a case. Everyone will discuss a case, and we will run through that and sort out what our action points are, and we will go away with normally about 3-4 action points to be acted on, which can then be reviewed at a later meeting.
Right.
So we initially had 3-hour meetings, and about an hour was left for the reviews, but we decided, because we wanted to run we run 2 meetings, so we do two topics. We would do elderly and possibly diabetes, COPD, or cardiology, and we have 2 hours for each, and we have 2 groups running back to back in the same venue, and the consultants can then swap over. We found that made it easier for consultants to attend, and it means that they're taken away from the hospital for fewer hours rather than travelling backwards and forwards.
Excellent.
So we be able to cover a lot of ground. We decided that we would do the follow-ups online rather than discussing them at the meeting and using valuable time at the meeting. We were trying to
Coordination, and I must ask you, how is coordination done? Is there one person who does this, or how does
There's
it work?
a team of coordinators, and they take minutes from the meeting, and so they will briefly discuss, and they'll make a list of the action plans. They'll bring along the case plans. When we submit the care plans prior to the meeting, we try and submit them at least a week before the MDG meeting, so that the details can be circulated to the specialities, so to psychiatry, to say elderly care consultants, and to social services, so we can get feedback and they can look at what is going to be discussed.
And who are these coordinators? What kind of background do they have?
Well, the head of the ICP that we have is Sue Young, and Sue, her background is as a practice manager, so a very experienced practice manager of a large practice in the local area. He knows the area very well, he's had lots of experience.
And Sue has a team
Sue
around
has a
her.
team. We have a lot of IT people, we have people
Right.
to help write the templates, and just facilitate the meetings, and just really drive towards what we're hoping to achieve. We had Mark working with us for some time, who'd I think come from Westminster, where it had been set up, and gave his input and his experience for us while we were setting
So
up
this
our
central
process.
team serves how many boroughs then? Is it across the? Would they have direct patient contact if a
No.
patient? They don't. So they're not there to respond to a patient. If a patient sort of said, "Well, something's not happening here within my
No.
plan," who does a patient talk to?
The doctor. The doctor.
So it's the GP, is it, who is the prime coordination for the clinical aspects, for the actual services?
Yes.
Care issue. Would you also still be the first point of contact?
Usually, yes, because social services would have some contact, but and one of the questions is the patient known to social services? What level of care have they had? What was the last contact that they had? But ultimately, most things are up to the GP to do. Harmony covers our out of hours, and that's been going for many years, and that has worked quite well. But currently, a lot of our out of hours calls are now screened by 111, which I think has some difficulties at the moment.
Right. And they wouldn't at this stage have any access to those care plans? They wouldn't?
No, unless they're on Coordinate My Care, but Harrow hasn't really gone into Coordinate My Care as fully as some other boroughs. So
Right.
Hillingdon, I think, have taken up Coordinate My Care, so then they would have more access.
Right. Benefits of this approach. What would you say are the benefits from the patient's point of view?
The patients get an opportunity to discuss their care as a whole, not just their medical care, but the social aspects, the psychological aspects, and also what the carers feel they need, what's working and what's not working. And we then have an opportunity to discuss with consultants to get things done quite quickly, and the patients are almost fast-tracked in certain areas. We can get things done more quickly. So, for instance, our memory clinic has a long waiting time. But if they're an MDG patient, we can get them pushed through more quickly because we've discussed them at the meeting.
Does this add on to your working day and your workload, or are there benefits in terms of
to be
saving
honest,
time?
it adds on to our workload,
Right.
but it can help. I think ultimately, if you've identified your problems before they happen, then you can take steps to avoid unnecessary hospital admissions. You can see where perhaps failings might be, or where patients might slip through the cracks, or try and identify things before they happen.
And I think there's evidence yet that it is leading to avoiding hospital admissions.
There is some evidence because a lot of the time it's making most doctors much more aware of alternative services and different ways of managing patients. For instance, in Harrow we have a STARS team who will go out to the patient's home and provide care for patients with, say, for instance, acute exacerbations of COPD. We can get rapid access physiotherapy and things like that. So there are certain situations where we can avoid admissions. One of the initial difficulties we had with the process was getting the care plans just right and getting the information, not having too much information, but having enough, and also tying it into QOF so that you weren't duplicating things unnecessarily. Developing a process for identifying patients by inviting them, by phoning them up, by getting them to do pre-screening. All those things save time, especially with older patients. And I think we've now got our care plans up and running nicely, and there's a lot of similarities with the care plans. A lot of the screening questions are pretty much the same, so it's less daunting. We're also looking at asking London Ambulance to tell us which patients they think we should be seeing, because we don't necessarily identify a lot of the frequent callers. So we're looking forward to doing that, and also having district nurses saying we'd like to discuss this, because the whole process should be quite inclusive and everyone can contribute.
So you start.
As a process, it's a good process because you're looking at the patient as a whole. You're not just looking at their heart failure or their leg ulcers. You're looking at everything as a whole and how it impacts on them and what we can do to make their quality of life better and their health.